the few of your water-soluble colleagues who could not, we are actually videotaping today. It's a real pleasure to introduce Nader Pouratian. Most of you may well know him, as he's been at UCLA for, I guess, a quarter of a century now. He's an undergraduate, with the exception that I'll mention in a moment, but did his undergraduate training here, did a neuroscience PhD here, medical school, and then went to the University of Virginia. 6 years of training in neurosurgery, so not your typical neuroscience path, but certainly one that puts him into an elite group of neuroscientists slash neurosurgeons who are able to make really unique contributions to the field. He's going to be talking today about work that he's doing involving deep brain stimulation. He's currently really very busy neurosurgeons here at UCLA, and will be shortly heading off to the operating room, so I will not go in further depth, rather that you hear him than his accolades. Thank you.
All right, so thank you for the opportunity to speak to all of you. It's not too loud. So I am going to speak about what we've learned about the function of the brain in patients with Parkinson's disease, and focusing on this concept of synchrony. And I'll explain that a bit further as I go through my talk. What I want to start with is a clinical perspective to give motivation to why we do the research that we do. So my field of neurosurgery is often called functional neurosurgery, or we might refer to it as restorative neurosurgery, and the surgeries that we do focus on improving patients' quality of life by intervening in some way with brain, spinal cord, or peripheral nerve function, sometimes by lesioning tissue, sometimes by stimulating tissue. But because we are focused on quality of life, it means that we really have to be very specific about our therapies, identifying the symptoms that affect patients and targeting those symptoms with the treatments that we recommend or don't recommend. The most common treatment that we use, or the sort of the core of treatments in a functional neurosurgical practice, is something called deep brain stimulation surgery, or deep brain stimulation, in which we implant an electrode deep into the brain in a very specific target, depending on the disease that we're treating, in order to deliver electrical current to that tissue. The advantage of this is that it's reversible. We can turn the electrode on and off, and the effect can wash in or wash out with that modulation of the current. Moreover, it's not binary, right? So we can modulate, we can turn the current up, we can turn it down, we can change the frequency with which we stimulate, there's different contacts on the electrode, we can do many different things in order to change it. That ends up being a very great testing ground, because we can deliver stimulation in different patterns and see the differential effect on the brain, and I'll make a couple comments about that along the way. So what we do is we put electrodes deep inside the brain. The most common target used in deep brain stimulation for Parkinson's disease is the subthalamic nucleus, which is part of the basal ganglia circuitry. At UCLA, we also implant the globus pallidus internus. The thalamus is rarely implanted for Parkinson's disease. That's only for patients who have tremor-dominant disease. But this cartoon is overly simplistic, but also highlights some complexity in that even though we target structures that we know of and we can see on MRI, there are many fibers and axonal pathways that navigate all around the electrodes that we are placing in the brain. So we really do have to understand how the different parts of the brain are connected, how the function is interconnected, and how we may be modulating that in a diseased brain. Again, to give you some perspective about how the surgery is done and how the operating room becomes my basically laboratory. The patient is on the operating room table here. There is an x-ray machine over the patient here. That's me operating. The patient is actually awake for the majority of the surgery. The patient has a stereotactic frame on his head. So for those of you who may do rodent work and use stereotactic frames in rodents or in non-human primates, this is the same thing except the human version. And we use an arc in order to precisely deliver a electrode or drive an electrode deep into the brain. While we are doing that, we can record electrophysiological activity. So in this case, clinically, we measure single unit activity. So each of these spikes that you can see here is a neuron that is firing, and we're looking for specific patterns of neurons. If we really want to, we can actually test movement. We'll do passive movements of the wrist, elbow, shoulder, what have you, in order to look for what we call kinesthetic cells. So we know that there are cells that respond to movement. There are also cells that respond to many other tasks that we can design to run in the operating room. We get an X-ray to make sure we're in the right place. Clinically, what we do is, and this is why we keep the patient awake, is we turn the stimulator on in order to see if we are able to improve their symptoms during surgery. So in someone who has tremor, we want to see the tremor go away. In someone who has rigidity or increased tone, we want to see that the rigidity goes away. We also look at bradykinesia, which is the rate at which someone will tap their fingers. Actually, one of my partner in neurology is Dr. Yvette Mordelon, who will come to the operating room. And what we do is we will select a certain contact. We will drive the voltage or current up. We'll look for therapeutic effect as well as mapping side effects. That's how we do the surgery. And I'll show you a video of a patient that we treated, just so you can see the effect of stimulation. This is someone who has tremor-dominant disease. And you can see he's got a resting tremor on the right hand. The left hand tremor you'll see in just a moment. And he's got a little bit of, you'll see some bradykinesia when he tries to do his finger tapping. Just in a moment, you'll see the tremor comes out on the left side as well. A little bit of slowness with his finger tapping, and he doesn't have a full amplitude with those movements. In just a moment, you'll see the stimulator turn on. And the most obvious thing that you'll see, the other things are harder to appreciate, there's no tremor. And this is basically instantaneous. As soon as the stimulator goes on, the tremor is completely gone. He taps a little bit faster. He's still a little bit low amplitude with this tapping. In this particular patient, his effect was so strong that he basically wanted to stop taking his medications, which we don't encourage patients to do, but it can be a very effective therapy. Just to show you some of the data about what we do. So this is, there have been several randomized clinical trials in Parkinson's disease for deep brain stimulation, in which people who are eligible candidates for deep brain stimulation get randomized to either best medical therapy or stimulation therapy. And what the patients that we primarily treat are patients who are a little bit further along in their disease. They don't just have the symptoms of Parkinson's disease that we classically talk about, which is tremor, bradykinesia, rigidity, but they also develop dyskinesia. So when the stimulator, when they take their medications, they're the opposite of what you expect with Parkinson's disease. They have extra movements, so almost like Huntington's disease. They have these extra movements. If you've seen Michael J. Fox lately, you see that he's moving too much, which is what you wouldn't expect from Parkinson's disease. Those are what dyskinesias are. A patient can make a diary of their day, how their day is throughout, and they get split up into different categories. In the group that got randomized to best medical therapy, 6 months later you'll see that it looks almost identical, the distribution of their day. But in the deep brain stimulation group, you can see it looks very different. And if we look at what happens, the amount of time per day, on average, when they are off or immobile, reduces from 6 hours down to 2 hours. And they're good on time, meaning they have a good response to their medication, no dyskinesias, actually feeling very good, increases from 3.5 or 3 hours per day up to 7.5 hours per day. So we have a lot of data like this, and I don't want to make this a clinical talk, but understand that there's a lot of data to support that deep brain stimulation works. However, it's an extremely cumbersome therapy. So I joke with Yvette, and I say, my part's the easy part. I just have to do brain surgery. She has to manage these patients after I implant them. She has to turn them on. She has to program them, adjust the stimulation, adjust the medications. The first several months they're coming in every 2 to 4 weeks for adjustments. Then they get into stable therapy where they come in every 3 months usually. It's very labor intensive, and the reason why is because we can modulate it, right? So patients like to have their programs changed, try and make things better. But the reason why they need continued therapy is because it's an incomplete therapy. It's a unidirectional system. It is a stimulator that delivers current, but has no idea what's going on with the brain. The only way the system knows what's going on with the brain is by having a physician assess, or a physician or a provider assess the patient, determine that there's something different, and then go in with a programmer, which is shown here, and adjust the stimulation. And physicians are necessary for closing the loop. So it's the biggest problem really is that it's not smart. In a world of smart technology, our phones know everywhere that we go. We don't know who else knows everywhere that we go, but our phones do for sure. We know a lot about people's behavior. We can sense things, and we are not taking advantage of that, mostly because we're using technology that's about 20 years old, and we're trying to move that forward. We also have to compensate for imperfect targeting. So I can do the best job possible in the operating room, and there's still imprecision and things that change patient variability that will land an electrode in a suboptimal spot, and we need to adjust for that with programming. A lot of the problems that we have is because we have an incomplete understanding of how Parkinson's disease, or any neuropsychiatric disease for that matter, affects brain function and brain circuits. And that's really what motivates the work that we are doing. We are trying to go from a not smart system, which is time-consuming, that's not based on physiology. It really does limit our dissemination to a smart system where we can detect the patient's own brain signals. We have some kind of real-time signal analysis, so it's some kind of classifier to tell us the patient's current symptomatic state, some kind of automated generator programming, brain stimulation, and then some real-time assessment of efficacy. So if you imagine if you have that, all I have to do in a perfect world is put the electrode in with a generator that can both sense and stimulate and has some kind of algorithm in it, and it can program itself, and we don't need to invest as much human time into programming and management, and we can focus on the other symptoms that patients really need help with. So that is the motivation for the work that we do, to try and understand these neural signals. And in order to do this, if we take a step back, it means that we want signals that tell us about the patient's symptoms, that correlate with symptomatology or disease severity. We also would like to see that those signals respond to treatment, so that when we stimulate, they change in response to the stimulation, and in a way that tells us how much they are improving. So those are the things that we look for. When I think about deep brain stimulation, 10 years ago when I started doing this work, when people asked me, how does deep brain stimulation work? I had a very easy answer, which was, I don't know. Because we really didn't know how it worked. Brain stimulators were placed in, it was an accident in sort of modern deep brain stimulation was an accidental observation by a French neurosurgeon, Dr. Benedict, who was doing a lesioning surgery, and with lesioning surgery you do these temporary stimulations in order to map the brain. And then he said, well, why don't we just do chronic stimulation, and it ended up working. But we didn't know how it worked. We thought it was mimicking a lesion. So I'm going to put forward an idea which more and more people are agree with, and I wouldn't say it's my idea alone, but I think the type of work that we are doing and others are doing are helping to propagate this idea, which is that when someone has a cardiac problem, you get a cardiac arrhythmia, you'll get atrial fibrillation, you'll get some other funny rhythm. The first thing a cardiologist does is get an EKG. They look at your heart through an electrical parameter. And then if you have a certain kind of abnormal rhythm, your doctor will tell you you need a pacemaker. And there's almost no one in the room who says, yeah, I know you think I should, I'm not going to do a pacemaker, right? You listen to your heart doctor when they say you need a pacemaker. I don't think the brain is that different. Although, when the brain gets sick, we develop brain arrhythmias. For a long time, a lot of the research in the brain is really focused on single unit activity, how a neuron fires in a single area, which is really intriguing. We all learned that the neuron is the basic unit of activity, or has the basic unit of activity in the brain. But we can also look at how areas of the brain develop oscillations, because we can, just like you do an EEG and you can see brain waves, you can put an electrode deep inside the brain or on the surface of the brain and listen to those brain waves in a very spatially focused manner. And it turns out that you can see differences in those oscillations if you analyze them and break them down into different frequency sources and identify arrhythmias. And if we're correct, we would say that a brain pacemaker basically tries to restore those brain arrhythmias, or those abnormal brain oscillations. One other idea that I want to propose is that we can't be overly obsessed with a single region of the brain. For a long time in this type of work, we were putting electrodes, let's say, in the subthalamic nucleus or the globus pallidus, and that's all we would study. We would say, well, the subthalamic nucleus has a lot of beta, which is a certain type of oscillation between 12 hertz and 35 hertz. But I think that was an artifact of what was convenient at the time. We know that disease affect networks. Everyone who is studying any kind of disease pattern in the brain mapping center or using MRI is looking at the entire brain, looking at patterns of changes across brain regions. The advent of resting state functional connectivity, tractography, everyone's looking at how diseases affect networks. So I don't think I need to convince you of that. We also know that the brain is very rich in connections. That an area like the subthalamic nucleus that people were very interested in, it turns out it has a lot of connections, a lot of different hyperdirect pathways, and so we need to try and tease those things out. And it's very possible that stimulation in slightly different areas engages different networks because of the rich connections that are present. We have a lot of data that deep brain stimulation doesn't actually modulate just a specific region, but has widespread activity. This is in an animal model showing that brain stimulation in the thalamus affects cortical regions remote from that area. This is using PET in patients who have deep brain stimulation for disorders of consciousness, showing increased cortical activity with thalamic stimulation in patients with disorders of consciousness. The other thing that's very compelling to talk about networks are two. One is that I can stimulate in Parkinson's disease either the subthalamic nucleus or the globus pallidus internus, and both work equally well. Which means that it can't be site-specific. There's something about me tapping into the network at one site or another, which tells you that it's not a focused therapy, it's a distributed therapy. But also, this is work by Michael Fox, who's at Harvard, looking at resting state connectivity patterns in different disease states. He didn't quite look at the different disease states, but basically showing that the areas that we target with deep brain stimulation are functionally related to the areas that are targeted with non-invasive stimulation, like transcranial magnetic stimulation. And so, again, if we can tap into the same network from different regions, it probably means that all of our therapies are network-based therapies. So there's a lot of data from many different areas saying we've got to look at these brain oscillations, and we really do have to look at networks at multi-region recordings instead of just focusing on a single region. There's lots of things I can do as a neurosurgeon that are unique. And that's what I really like to do in my clinical practice as well as in my laboratory, is take advantage of the unique opportunities that are available to me as a neurosurgeon to study the human brain. That's much of what motivated me to go into what I do now. I was a young undergrad at UCLA and was at a Society for Neuroscience conference, and I saw George Ogeman speak, who's now retired, but did a lot of, he's a neurosurgeon, he did a lot of work in neuroscience, understanding the brain and language. And he inspired me. He said, a neurosurgeon has a live human brain in front of them. It's a pity not to take advantage of it to understand the human brain. And so that's really what motivated me and got me to where I am. So all of my patients get brain imaging. We get high resolution imaging because we need it in order to target the brain. And so we take advantage of that to look at where our electrodes end up, if we use stimulation field models, where the activation is, what networks might be engaged in order to identify the sweet spot for stimulation. I'm not going to be talking about that today. I also do recordings during surgery. And that is a really unique opportunity. So why do this during surgery? Why not just use EEG? Well, if I can put an electrode directly on the surface of the brain or directly in the brain, I have a much greater spatial certainty about where my signals are coming from, whereas with EEG you need to do some kind of assumptions or back calculations in order to do source localization, and even then it's not fantastic. And also, when you record signals from outside of the head, the signals get filtered by the scalp and skull, and you don't get high-frequency signals as much as you would with directly invasive recording. So this is really what I'm going to be focusing on today. The last thing we can do is we can do recordings outside of surgery with newer devices. This isn't, that's just an EEG, but newer devices that are research-based that allow chronic recordings from the brain in people who have implanted deep brain stimulation devices. So I'm going to tell you a little bit about our methodology that I've used for the rest of the talk. I am, as I said, putting electrodes on patients' brains for deep brain stimulation for Parkinson's disease. What I'll do is, with their consent, obviously, the same burr hole I use, the same perforation I make in the skull in order to place the electrode for surgery, I will slip an electrode or a strip of electrodes over the cortical surface, usually towards the primary motor cortex, in order to record from the motor network. That's where we started. So I would record from the primary motor cortex, premotor cortices, as well as the motor regions of the subthalamic nucleus or the globus pallidus, and I can record simultaneously. So this is an X-ray from the operating room. You can see the deep brain stimulation lead in place, and ECOG grid in place, and we try and we'll record from both of those. We do cortical extractions. We will project this X-ray onto the cortical surface in order to know where our electrodes are. We can localize them. We can also localize our deep brain stimulation electrode. And now we have multi-site recordings in a human. More recently, or the last couple of years, we don't just put them here. We can now, whenever I can access for my burr hole, I don't do additional burr holes. But we have interest, for example, in the right inferior frontal gyrus, which is involved in action suppression or stopping. So I'll place an electrode down towards the right inferior frontal gyrus. We will also, when it's possible, put an electrode interhemispheric. So I can slide an electrode sometimes between the two hemispheres in order to record from the pre-SMA or the SMA region in order to look at different networks that might be of interest to us. Just to show you the kind of data that we record, we are recording from our deep brain stimulation lead itself, so these contacts are still not skinny. They're 1.5 millimeters large and they're circumferential, although with newer devices they're segmented a little bit more. But you can see I can slowly advance my lead towards target, so imagine this is going deeper and deeper and deeper, and this is a frequency decomposition, or basically a Fourier transform, to look at the power of different frequencies as we advance our electrode towards target. And even someone who hasn't done any of this work can easily tell that the color pattern here looks very different than the color pattern here, where when we engage our target at the globus pallidus, we have this high frequency band which hadn't been described before, but we characterized. And we also get this increased beta, which is very well recognized throughout the Parkinson's disease literature. Here are simultaneous recordings from the cortex as well as from the globus pallidus during rest, which is the red line, and can't quite see it. The other line, the black line is the what happens during movement. And same thing in the globus pallidus. We have 4 different types of recordings here. And here's that same color spectrum here. It's just zoomed into the bottom part of this. But you can also very easily see these segments where there's a solid black line followed by a dotted black line. After the dotted black line, you see a very serious suppression of this alpha low beta region. When the patient, and this is when the patient is moving, they rest, movement, rest, movement. So very easily to record signals. Once you're there, they're easy to record if you get the electrode there. But very reproducible movement-related changes in the signals, both at the motor cortex as well as in the globus pallidus. This is a lot of the work that I started with. I just needed to have a proof of concept. that I can demonstrate target engagement, and that I can see basic signal changes simultaneously reported from the motor cortex and deep within the brain. And this is just simple power analysis at this point. A couple other things that people may or may not be familiar with, and I'm not going to get too technical for this talk, but I do want to bring up some important concepts of coherence or coherence phase synchrony. The idea that two signals in two different parts of the brain may be oscillating with some kind of consistency, with some kind of phase lock. So these signals would be 100% coherent because they absolutely follow one another. This is the same idea that's used in resting state functional MRI, looking at areas that oscillate or fluctuate at the same rate. We know that these coherences exist, particularly in the beta range, or alpha and beta ranges. And this is something that I find that really inspired me to keep going when I was first trying to figure out exactly where we were going to go with all this research. But as I showed you before, we slowly advance our electrode to target. So this is our deep brain stimulation electrode going closer and closer and closer to target, which is at 12. And this is our ECOG strip, and 5 is where the motor cortex is. And one thing you'll see is as we get closer and closer to our target, the coherence increases significantly in the beta range between the motor cortex and our GPI. And this is a really critical finding because what it tells us is that we can actually tell when we're engaging the motor network or recording from multiple sites in the motor network because those areas are coherent with one another. And that's what led me down to this path of, well, is this synchrony or is this coherence what's actually going wrong in Parkinson's disease? One other measure that we'll be referring to a lot is phase amplitude coupling. Phase amplitude coupling is not the coupling of two signals in two different sites at the same frequency, but that the phase of a lower frequency signal, so here, determines the amplitude of a higher frequency signal. So it's phase amplitude coupling. And that has been described, was described in epilepsy patients before, but has become an area of interest for us as well. And I think it's a sign of some kind of phase locking again, but now you're locking a higher frequency signal to the phase of a lower one, but it represents synchrony in a local fashion. So again, going back to some earlier work, this is actually data that I collected when I was still at the University of Virginia in an epilepsy patient in whom we had these cortical strips, these ECOG strips on the surface of the brain, but also had some thalamic electrodes deep within the brain. And what I wanted to know was, how do these signals in the thalamus and the cortex relate? Everyone knows that the thalamus projects to the cortex. But is there some kind of relationship between these areas? And what we found is, in fact, if you look at these cortical signals and you look at the thalamic signals, there's actually coherence in very narrow bands in some of these pairs of electrodes. I'm not going to show the data today, but I will tell you that these areas where there's strong coherence, if you do diffusion tractography and you look at, especially if you use probabilistic tractography, if you look at the strength and the probability of connectivity between these contacts, the stronger the probability, the stronger the coherence is. So we're showing some structural functional relationships between the thalamus and cortex. But more importantly, what we see is that there's phase amplitude coupling between the thalamus, so the thalamic signals seem to be coupled with the cortical signals. So these are what these bubbles, these hotspots show, where the phase of the cortical signals the phase of the cortical signals are related to the amplitude of the phase of the thalamic signal relates to the amplitude of the cortical signals. And what we found also, it's not shown here, but the other insight that we had here is that this was a very dynamic process. Meaning, if we look over time at, we can start anywhere on this, so let me start here. So if we look at theta power, so theta is 4 to 8 hertz in the cortex, and we look at the power on a minute-to-minute basis, and you can use any scale you want. The reason why we use minute is because in order to calculate phase amplitude coupling, you need a certain amount of data in order to get the phase amplitude coupling. But if you look at the average power over a minute, it changes over time. And this is in an awake, behaving subject, no, this task-free design. But if you also look at the thalamocortical coherence, so how the thalamus is coherent with the cortex, it varies over time. And if you regress the power versus the coherence, they're very tightly coupled. This is a significant coupling. It turns out that if you look at thalamocortical PAC, so how the thalamus and cortex are coupled to one another, they are also fluctuations over time, and that's very tightly coupled. And finally, cortical PAC is related to all these things. So everything is very tightly interrelated, and they're temporally dynamic. The temporal dynamics of the cortical phase amplitude coupling is something that wasn't very well appreciated, but something that we struggled with because we realized when we were first starting to do this that depending on what snippet of data we looked at, the phase amplitude coupling was there or wasn't there, and made us think, well, is it so dynamic? And so we in fact did say that it was dynamic. But another thing that this highlights and led to our Parkinson's work is that this phase amplitude coupling is due to complex interaction of signals across brain regions. So phase amplitude coupling is not an isolated event that's cortical in nature, but it can be related to signals coming and flowing from other areas. We did do some Granger causal work as well here, showing that the signals actually flow from the thalamus to the cortex and drive the phase amplitude coupling at the cortex. All right, so that's the background. We needed to figure out what the signals were in Parkinson's disease. I was strongly convinced that we needed to do a network approach, and then I really thought that these signals must be dynamic over time. And the literature at the time when I started was, people, as I said, studied motor cortex, they studied globus pallidus, studied STN, very similar findings in all these different places, that there was beta in the motor cortex in all these regions, that there's phase amplitude coupling in these different regions, but no one, I wouldn't say no one, not many people were looking across these regions. And we started to say, well, how are these different regions interconnected to one another? So there's definitely too much beta. And if beta is actually pathological, then therapy that improves your symptoms should reduce that beta. And that was inconsistent literature. It was not consistent that if you turn the stimulant on, that the beta actually decreases in different parts of the brain. And then another interesting thing that came up is that beta, which is a broad range from 12 hertz up to 30 or 35 hertz, depending on where you read or where you look, is actually a very broad range. And it was defined before we did a lot of this work. It was defined based on the EEG literature. And we started to see in our data that not all beta was the same, that there's actually two different betas. There's a low beta and high beta. And so we started to dive into that a bit more as well. This is not in synchrony, but does start to show some ideas that we can get from our Parkinson's patients. Very simple experiment we did in the operating room where we had patients, we externally cued them to open and close their hand, which is basically me telling them, move your hand or stop moving your hand. And we did this both in patients with essential tremor and with Parkinson's disease, and we'll just focus here, which is across the central sulcus. You can see there's very similar patterns between essential tremor and Parkinson's disease, meaning the timing is the same, but the amount of beta activation, the ability to modulate this beta range, or the alpha and beta range, is significantly less in patients with Parkinson's disease Parkinson's disease compared to essential tremor. This high gamma, which actually represents movement, we think, or integrated neuronal activity, all occurs at the dotted line when movement actually occurs. So the timing looks relatively the same when you're cued to do something. We know Parkinson's patients, when they're cued to do something, they do fairly well, although the magnitude of activation was different between the two groups. Now this was an interesting part, which is that we said, okay, now I'm not going to tell you when to move, I'm going to just tell you move whenever you want. And we did this with essential tremor and Parkinson's disease patients, and what we see is in the Parkinson's disease patients, look, you see signal changes up to 1 second before they actually move. Whereas in the essential tremor patients, it's really just 100, 150 milliseconds before. So Parkinson's patients are trying to move, their brain is activating to initiate the movement, but they're not actually able to initiate the movement. And this is a nice demonstration of problems with beta or beta-gamma dissociation. Everyone always assumes that you suppress your beta, you activate your gamma, that's what happens when you move. But this actually shows that you can dissociate the two, that there's something, again, very special about the beta in Parkinson's disease patients that is different. They're able to initiate or prepare to move before they actually move. I shouldn't say they're able to. They start to or initiate their movement before they actually move, far before, long before an ET patient does. Okay. Now getting deeper into the brain, I'm going to show you some coupling or some synchrony pictures. And what I've done is I've included a cartoon in each slide to show you where we're recording from. And this is recording from the globus pallidus internus down in this region. And we have recordings at rest as well as during movement, and then we have GPE recordings as well, but we won't focus on that at this moment. Now, until this work, everyone thought that phase amplitude coupling was necessarily abnormal. That when you were in a state of phase amplitude coupling, it was pathological. That's what all the literature said in the motor cortex work. And then, so we started looking at our data, and we found that, in fact, a lot of people seem to have this coupling. We said, great, our Parkinson's disease patients have this phase amplitude coupling. It's diseased. It's bad. But then when we compared it, and we looked at our most sick people, so the highest UPDRS, Unified Parkinson's Disease Rating Scale, and we compared it to the amount of phase amplitude coupling, it turns out in the globus pallidus, this ended up being a relatively normal signal. You lose this signal when you develop Parkinson's disease, or the more symptomatic you are of your Parkinson's disease, which was very interesting to us, which is the opposite of what we wanted to see at the moment, but it is what it is. We also showed that patients who are more symptomatic are less able to modulate their phase amplitude coupling than patients who have less symptoms. So that might be an artifact of the fact that they have more of that signal to begin with. But in any case, this does show, importantly, getting back to my original idea, that we have a biomarker of disease severity, or symptom severity. If you have the signal, you seem to be less symptomatic of your disease. When you lose the signal, you are more symptomatic of your disease. Remember, that was the first thing I said we need for our closed-loop system, a biomarker of disease state or symptom state. We also look up at the cortex for this. And in this case, this has been shown already by another group, and we were able to reproduce it, which is always good from two different centers. Two different neurosurgeons can do the same thing since it's such a unique environment to record from the brain. But this is the motor cortex. That's that phase amplitude coupling curve. And what you can see is that there's a lot of phase amplitude coupling in the motor cortex of patients with Parkinson's disease. The area where we have the greatest phase amplitude coupling seems to correlate with this area of having a high beta peak in the motor cortex. So when the motor cortex has a lot of high beta, and it happens to have a lot of phase amplitude coupling, again, largely in this high beta region. And when we regress this against our bradykinesia or the severity of symptoms, again, this signal, the more of this you have, the more symptomatic you seem to be. These are just some further analyses of that same data. Again, so now we have biosignals, biomarkers, both in the cortex and deep in the brain that seem to correlate with symptom severity. So it's a really good sign for trying to design a closed-loop system. And the other thing I'll highlight here, because I want to differentiate it for this crowd, this is all mostly in the high beta range. This is a high beta gamma PAC. So high beta, in our opinion so far, seems to be the more problematic signal in patients with Parkinson's disease. Actually, I do want to go back to here. The interesting thing here is this signal that correlates most strongly with normal function is low beta gamma. So low beta seems to be a normal signal in the globus pallidus. High beta seems to be the pathological signal here in the motor cortex. So it's good that we were able to differentiate those. Now we look deep in the brain, and remember I said the next thing is not only do we have to have signals that represent symptom severity, we need to have a signal that responds to the stimulation. If it doesn't respond to stimulation, we can't really rely on it in the long term. So we looked back at our globus pallidus and we said, so what happens when we turn our stimulator on? Doing these recordings with stimulation is non-trivial. It took us a long time to figure out how to do it with a lot of noise cancellation. But what we do see is that low beta is suppressed with stimulation. That was interesting to us. We didn't expect it, but high beta isn't modulated at all. The other thing is the motor cortex, even though we have this high beta peak, does not change whatsoever in response to stimulation. At least the power of it, the high beta power does not change at all. So high beta looked like it's a really interesting signal from a power perspective because it peaks, it correlates with having Parkinson's disease, but it doesn't seem to respond to treatment at all. So not a good idea, not a good bias signal. But then we said, well, what about this phase amplitude coupling that we saw before? So again, beta does not change on or off stimulation, but look what happens to our phase amplitude coupling when the DBS is off versus when the DBS is on. So we get suppression of that phase amplitude coupling with effective stimulation. Again, this is just doing some analytic work with the same signal that's depicted here. And we see that improvement in bradykinesia seems to correlate with this change in this high beta gamma phase amplitude coupling. So rather than looking at power is what we've looked at for the most part over the last decade. It turns out power itself is not very informative of what's going on in the brain or the therapeutic effect of stimulation, but this phase amplitude coupling, or this synchrony of sorts in the cortex, is being modulated by the deep brain stimulation. So we're going to see some disruption of this coupling in the motor cortex. Fortunately, just before us, fortunately for the science, not fortunately for us, another group saw a similar effect with stimulation in a different region of the brain. This is in the subthalamic nucleus. This is Phil Slar's group up at UCSF. And he was able to show similarly in the motor cortex, you turn the stimulator on, mind you, they are stimulating in a different region, in the subthalamic nucleus versus the lobus pallidus. You turn the stimulator on, the phase amplitude coupling in the motor cortex goes away, it comes back when you turn the stimulator off. They also similarly found that power is not modulated at the cortex by deep brain stimulation. So there's a network level modulation of this cortical synchrony, this cortical phase amplitude coupling. So I'm going to go into coherence again. Remember I said we didn't see any change here in the power of the motor cortical signals. But I was very fixated on this idea that synchrony, how is it that we're getting a change in the phase amplitude coupling, but the power isn't changing? You know, can you get a dissociation between these two? Is there something else going on in the realm of phase synchrony? And you know, I said that we have a lot of coherence between, this is between the pallidum and the cortex, the BPI and motor cortex, which you see here. With stimulation, that seems to go down. And in particular, if we look at the low beta range, so that 12 to 20, which I said I think is more normal beta activity, normal beta motor activity, there's no real pattern. It's just sort of all over the place. But if we look at high beta actually consistently gets suppressed with therapeutic stimulation. So high beta coherence, phase synchrony, decreases with therapeutic stimulation. So now we have this picture that therapeutic deep brain stimulation does not change cortical power with stimulation at either target, but it does suppress cortical PSA and it suppresses network-wide coherence and coupling. And so the question that comes up is, how does this local phase amplitude coupling change if the underlying oscillatory power does not change? And is network synchrony related to, or does it drive that cortical PSC? So we've got two different observations. We've got coherence or phase synchrony across the network is changing with therapeutic stimulation. We've got the motor cortex PAC changing. Are those related to one another? And so let me go to this slide. So now we take a deeper dive into the temporal dynamics of the signal. So we've been doing these analyses where we just look at the signal over 30 seconds or a minute worth of time, but the brain doesn't work at 30-second intervals. It works more on instantaneous time. And the field has really moved toward this idea of doing analysis of instantaneous bursts or instantaneous power, as well as waveform shape, in order to understand what might be underlying all this. So what you can do is you can take a unfiltered LFP signal here, and you can look at the beta power. So this is the analytic power over time. You can see where the beta power seems to escalate for short periods of time. These are what we call beta bursts. You can now start looking at how long those beta bursts are. So it's possible, imagine, that you can change how long you're in a beta burst without changing the overall power if you just redistribute time in a burst, or duration of a burst and duration in non-burst periods. And this was discussed by multiple groups, and we've been looking at it as well. And you can also go a step further and look at how bursts might occur in the motor cortex and subthalamus nucleus at the same time. And it turns out these bursts do occur at the same time overall. Let me see. And if you look at the phase synchrony, so remember this is motor cortex and subthalamus nucleus. This is from another group, I believe from the Oxford group, but they show that phase synchrony is actually increased during these period of bursts. So we went through this a little. Sorry, one more background. The other thing you can do is look at the instantaneous waveform shape. So even though when we decompose our signals, we imagine these perfect sinusoidal waves that are extracted, the waves are actually not perfectly sinusoidal, and you can have different waveform shapes. And waveform shapes can change under different conditions. So for the sake of time, I'm not going to get too far into that, but I wanted to highlight that can be done. Slightly out of order. All right, so this is some work that one of my graduate students, Andrew O'Keefe, is working on, hopefully writing up soon. But we know that, so this is the same power we saw, that there's increased high beta power in patients with Parkinson's disease compared to essential tremor patients. So this is the first thing I want to show you. It turns out that same increased power is accompanied by longer burst periods. So you can imagine there can be increased power because you have higher, more frequent bursts of the same duration, or you can have longer bursts, or both. But if you look at average burst duration in this period, it's the only area in high beta where you have longer bursts. And we see that distribution here, if you compare the ET and the PD subjects, you see the rightward shift of the reddish curve is the PD patients have, on average, longer burst duration. And interestingly, the longer your mean burst duration, the more symptomatic you seem to be from your Parkinson's disease. So we are seeing this idea that burst duration is important. But now we're trying to link all this stuff together. We said, okay, well, I know there's a synchrony thing. I know there's this phase amplitude coupling thing. How do bursts fit in the middle? And are they the link between the phase amplitude coupling, the excess synchrony that we see in the motor cortex, and the synchrony we see across the different parts of the network? So we looked at these periods of bursts. So this is the power, the instantaneous power of the signal across multiple bursts, and you can see the rise in the power of high beta. And here's the simultaneous phase synchrony index from motor cortical phase synchrony index, so premotor motor. And what you'll see is consistently the synchrony increases immediately prior to the onset of a burst. So I think what we're seeing here is that there's this period of increased synchrony that drives the burst. And then we look at this, we said, well, now that we have our data separated into burst and non-burst periods, we can collapse it all together. Remember, I said we need 30 seconds to get a good phase amplitude coupling. But we can just take all of our data that's in a burst period and all the data that's in a non-burst period, we can see if there's phase amplitude coupling. And it turns out if we look at all the data from a non-burst period, we have no phase amplitude coupling. But if we look at the data in a burst period, we have phase amplitude coupling. Which is very powerful because now we've linked everything together. And I think what we see is that there's periods of increased high beta synchrony across sites leads to, and I did show this part, changes in the high beta waveform, and periods of increased high beta bursting. So the synchrony leads to these high beta bursting, during which this motor cortical PAC is elevated. And that corresponds to PD symptomatology. So now we're able to link all these phenomena together. And that's why when we deliver, we think, our theory, deep brain stimulation, actually the fundamental process is interfering with this synchrony, and interfering with the synchrony ends up decreasing this phase-amplitude coupling as an epiphenomenon of the disruption of the synchrony across multiple sites in the brain. So we have an experiment, which is really interesting, and it's not quite done yet. But we said, well, we know that some stimulation works really well, which is high-frequency stimulation. We also have low-frequency stimulation. And what we have found preliminarily is that low-frequency, the nice thing about this is low-frequency stimulation still modulates cortical signals, or signals overall. But it doesn't change everything. And it's not therapeutic either. So this is sort of our goals here. We know what high-frequency stimulation does. We are looking at what low-frequency stimulation does. And low-frequency stimulation changes your local beta power in the deep brain. But it turns out it does not disrupt the coupling across the different parts of the brain and does not disrupt cortical PAC. So again, lending to this idea that you can change some local parameters but not change network parameters, and you'll still be diseased. I'm not going to read through this. It's a summary of everything, but the highlights really are that low beta, even though we've talked about beta as this huge signal from 12 to 35, low beta really is this local signal, and I think it's part of normal physiology. It's what's modulated with normal movement. But high beta seems to be most tightly linked to the Parkinson disease pathophysiology. It is what seems to be coupled across brain regions and seems to be driving the phase amplitude coupling. So the really exciting stuff about I love what I'm doing in Parkinson's disease. It's really interesting, but I think it opens doors to study other diseases. So for a long time in deep brain stimulation, what we've done is we have a device, we put it in, we think, oh, stimulate this part of the brain, it's going to work really well. And now that we have a framework for Parkinson's disease to say, well, now we start to understand that stimulation affects networks, we have to look at coherence, we have to look at how different parts of the brain are reacting. We use this data, myself and Samir Sheth, who was my co-MSTP student and is now a neurosurgeon like me, but at Baylor. And we proposed to the NIH as part of the BRAIN initiative to say, this is what we got to do for depression. We have to take 12 patients, 10 or 12 patients, and put deep brain stimulation electrodes in their brain. We also have to monitor their brain. We're going to look at these networks, and we're going to do a very similar analysis with different parts of the brain, the same underlying concept that we're looking at network modulation with these electrodes. We're also going to look at brain states of more depressed or more happy, to be very specific about what we're going to do. But it's interesting, we're able to show it in a disease that we know is therapeutic. We're hoping to use it to now develop therapies for other diseases as well. Just finishing up here, thank you, and I think this is extremely important. None of this work is really possible without the patients who volunteer to do what they do. And patients always want to participate in clinical trials that there's some kind of therapeutic opportunity. Patients who do this know that they will never directly benefit from what I'm doing with them. And so they spend time with us in the operating room. They allow me to put an extra electrode in their brain or two, all in the spirit of trying to learn more about Parkinson's disease and learning more about the brain. And this has really been supported by the BRAIN Initiative work as well as other NIH agencies. That's just highlighting that. And those are that's my team. They're an outstanding team. Thank you very much.
All right, well, maybe that will inspire one or two of you to think about the extra 10 years beyond neuroscience training to be able to do this sort of work. It strikes me that there's so much beneath the surface of what we see with our functional connectivity imaging. We see many ways that this is formed back in innovation, which we analyze in work those experiments where there's such a dimensionality of the data that we don't know a way to do it.
I think we have a unique opportunity to study it, which is that we have now we can compare the two, right? So Marco and I have been working with help in the Vision Clinic to know how to do functional MRI engaged with stimulators. And I think one of the things we need to do is direct the target protocol is look at these network changes, but then also look at the patients. And that's why we sort of added on that we're going to look at resting state fMRI and compare them. I'm afraid that it's not going to show the richness of the spectrum that we see. But it'll be really important to know what it does show, or how they correlate with each other, or how they compare to one another. Yeah, question back?
One of your slides that appeared, and I may be wrong because it was very small, there is that the phase amplitude coupling between the beta and the gamma oscillation was phase invariant. It was always at 0 radius. Is there a change in that at all, and does that mean anything in the context of the simulation?
So we've looked a lot. I'll start by saying I don't have a direct answer for you, mostly because when we've looked at the phase encoding or the phase dependency, there hasn't been as consistent a pattern as I would like for there to be. We don't really see, because that was one of the things, could you have continued phase anticoupling but at a different phase? We haven't quite seen that, although it's been reported in other areas, especially with sleep and anesthesia, that the phase will suddenly change, but we haven't seen that.
Okay, first of all, we mentioned a couple of times you were an anger here, you were also a grad student here. I was children here. And say it was a really well spent time because you're doing amazing work. I wonder, given that you have this wealth of data, what about computational approach so that you can
Yes.
model all this stuff and you figure out how the model is organized? Is that the model fits the best this kind of data? That should actually give you information how to actually feed the patient.
Yes, so that's been on our radar. I don't have the, yes. Well, one thing we've thought a lot about is, the assumption here is that I always have the electrode in the right spot, right? Which you don't know that I actually do. I mean, I think I'm good, but I'm not. No surgeon is perfect in terms of getting the electrode in the exact same spot, and so some kind of analysis of what the signals we see, how patients respond to the stimulation based on what the signals look like, and then again, this is all direct hypothesis testing versus some kind of more complex modeling of the signals. So we need to get there. I just don't have the know-how and I haven't had the bandwidth to do it, but I think it needs to be done. Yeah.
So in the beginning of the presentation, you mentioned that targeting the subthalamic nucleus and local pallid synchronous work equally well. What are the deciding factors? Is it like per patient?
It's per patient ultimately. The difference is, interestingly, subthalamic nucleus, you reduce your medications a little bit more, even though they're equally effective with the motor component. And there's more side effects. So it's side effect driven to a large extent. And that probably has to do with activation of other fibers and other regions. Subthalamic nucleus is a much more compact nucleus than the globus pallidus. And so within a couple millimeters, you're sort of in a different subregion, the limbic subregion, with other projections of the to other parts of the brain. That's another part of our work, which I haven't shown here, is actually looking at the spatial topography of the subthalamic nucleus with different behavioral paths and saying, well, this part of the nucleus responds to this path versus that part of the nucleus responds to a different path.
All right, I think we'll get you back to the
Thank
operator.
you. Thank you.